us today on PCPCC's National Monthly Briefing. This month's theme at the PCPCC has been focused around the topic of state innovations. Alongside our partners and stakeholders, the PCPCC is dedicated to advancing the medical home model and highlighting experiences and stories from the field as various states implement PCMH programs across the country. You can learn more about both public and private medical home results and activities on our website, pcpcc.org. Today's briefing will provide an inside look at Independence Blue Cross's PCMH initiative called the Pennsylvania Chronic Care Initiative. In addition, you'll be provided with insights on the multi-payer Advanced Primary Care Practice Demonstration Program, including Vermont's program. Before I introduce today's speakers, I'd like to go over a few announcements and general housekeeping items. Don't forget to register for PCPCC's upcoming Western Regional Conference in Denver, Colorado on June 9th and 10th. We have a terrific lineup of speakers at the conference and hope you'll join us in Colorado. You can find more details on our website. Our theme for next month will be on medication management. Join us on May 15th to hear from Dr. Tony Morial, who will talk about the VA's patient-aligned care teams and how they are incorporating clinical pharmacists into the medical home. Then on May 22nd, our national briefing will feature Dr. Brian Isitz from the University of Minnesota College of Pharmacy, who will talk about Minnesota's experience with medication management. Again, you can visit pcpcc.org to learn more. As with all of our national briefings, we will provide time for question and answer and want to make this as interactive as possible. So please use the webinar software to ask questions or provide comments. To do this, submit your questions in writing using the drop-down question box on your screen. During the last 15 minutes, after Rich and Lisa have finished presenting, I will open it up for Q&A from the audience. Also, please note that the slides and today's recorded presentation will be posted to PCPCC's website within the next 24 hours. Now, it's with great pleasure that I introduce today's speakers. First, we have Dr. Richard Snyder, who is the Senior Vice President and Chief Medical Officer at Independence Blue Cross. Rich currently leads IBC's efforts to improve the quality of patient care by transforming all primary care delivery to the patient-centered medical home model. Our second presenter will be Dr. Lisa Dulce-Watkins, who is the former Associate Director of the Vermont Blueprint for Health. Lisa is a pediatrician who transitioned into the field of public health and health information in the late 90s. In her current role, Lisa is now collaborating with Milbank Memorial Fund and the Association for State and Territorial Health Organizations, among others, to advocate for the continued support for health system reform nationally and at the state level. Now I'll turn it over to Dr. Snyder.
Good afternoon, everyone. Since the introduction mentioned the Chronic Care Initiative, I'm going to go to my next slide here. All right, there we go. So first, let me give you a little bit of a picture about our environment in Philadelphia, because it is in part what triggered us to become involved in the Chronic Care Commission in Pennsylvania and as part of a major player in the Chronic Care Initiative, which promoted the adoption of the patient-centered medical home as a model of care delivery. So in Philadelphia, if you look at the left-hand side of the slide, this is the environment we work in. Lots of hospitals, a lot of academic centers. There's about 50% of the physician population is employed. There's a lot of financial integration, meaning that hospitals get together and negotiate contracts as systems, so they leverage those relationships to get rates out of the payers. But there's very little clinical integration. You can't get information sent from one hospital to another very easily. The specialist to primary care ratio is about 4 to 1, and specialists have been valued far more than primary care physicians in Philadelphia, and a lot more than primary care physicians, or a lot less. Primary care physicians have been valued a lot less in Philadelphia than they have in a lot of the other more urban, the more rural parts of Pennsylvania. Payer contracts have historically rewarded volume, fee-for-service type contracts. There's not a whole lot of integrating technology, although we are working on that today. And so what have we as payers in Philadelphia done? We've done all the M's, UM, CM, DM, and other weird kinds of management to try and control cost and quality. Yet with all of this delivery of health care in Philadelphia, we are, if you now look to the right top corner of the slide, in the top 5 amongst MSAs in the United States for utilization and cost of care for the past decade. Actually, probably longer, but I am certain for the past decade. Overall quality is pretty average in spite of some centers of excellence. And in part that's because patients are getting care in hospitals that look a whole lot like hospitals in other major metropolitan areas. And then in terms of satisfaction, whether you're looking at HCAHPS scores or health plan CAHPS scores, the satisfaction is average or less than average. So people aren't terribly satisfied in this region. And it is why 8 years ago or thereabouts, the governor, then Governor Rendell, initiated the Chronic Care Commission with an effort to look at how to improve the care for chronically ill patients in the Commonwealth. And the initial chronic care initiative rollout effort to promote medical homes was in Philadelphia. It involved 32 volunteer practices, 150 docs, 250,000 patients. And I'll show you a little bit of information on that. However, based on the early findings amongst our population, and we make up a pretty significant proportion of the members and the patients in the Philadelphia area, we have decided to make this our objective as a kind of a hallmark of our network strategy to grow medical homes. And so I will also show you some data and outcomes related to all of our medical homes, which far exceed the original 32 at this point. In any event, in the circle, the market reaction was that purchasers in this market are demanding high-value care. They want to steer patients to lower-cost settings. They want patients to get care in better coordinated, higher quality settings. And of course, some more recent ads there, the public and private exchanges have really changed things. Reference-based pricing is lurking around the edges, not terribly popular here yet. And payers, we've really changed our strategy significantly. We've promoted the medical home and the ACO concept, with medical homes really serving as the foundation for the accountable care organizations. So let's go to my next slide here. All right, can you advance the slide for me? It's not advancing. There we go. Our strategy wheel. After a lot of, now we've overshot. Okay, let's go back here. One more should go. In a moment, you'll get back the strategy wheel. Our primary focus was to strengthen primary care. And with that, we started with payment reform by changing the way we pay primary care physicians. We raised primary care physicians' reimbursement by 10%, and we took that money out of the specialist hide by adjusting fee schedules on the specialist side. We then doubled our long-standing and then we decided that ultimately we want to get out of the business of having a lot of nurses working at Independence Blue Cross, so we decided to insource disease management. So we now have full control of the spectrum of care management services, from preventive services, disease management, decision support, case management, etc. And we've gone to a health coach model which aligns one member with one nurse over time. That allows me to now, as patients become engaged in patient-centered medical homes, and as we pay them more to take better care of our patients, following the tenets of the medical home, better access, better coordination, self-management skills training, etc. I want to get out of the business of having nurses and move that into the medical homes. So we want to integrate the care managers in the medical homes. And then finally, third on that wheel, the accountable care payment model. We've changed all of our hospital contracts to contracts that basically reward hospitals and doctors for working together. And then the fourth leg of the strategy, which we're not going to talk about today, was the provider engagement strategy. We wanted to provide technology and information to providers so that they can actually successfully manage care better. And there we go. There is a bit of a delay. So with the increased pay to primary care physicians and then supporting physicians with consultation, licensing, we pay the license fee for the American College of Physicians tools to help practices transform. We provide many different kinds of reports and tools through our physician portal to physicians that help them to manage care in an ongoing fashion with fairly real-time data, including care gaps, hospital census reports, etc. With the advent of all this support, you can see what happened to the adoption of medical homes. We went from the original 32 practices to now we're at 297 practices. 41% of the unique primary care physicians in the Philadelphia region are practicing in a patient-centered medical home, and about 40% of our members, we're representing HMO members here, are getting their care in medical homes. But in actuality, when we look at with reasonable attribution logic, the PPO population, it's a similar percentage. And then the ACOs, the only thing I want to say about this is everybody's talking about ACOs, but in reality, I think our contract is a bit different. The hospital contract, we will not renew a hospital contract unless they get into an ACO type contract with us. And that means there is a parallel contract with a separate legal entity, usually a PHO or something that they have, a legal entity that the hospital has on the side, that has physician and hospital executive governance, and any shared savings from the ACO contract goes into that separate legal entity and gets distributed with at least a third and up to a half of the dollars flowing to the physicians. And this is yet a second layer of potential earn for primary care physicians, as you can see in that little diagram. They can participate and, in fact, in most cases, are the foundation for the ACO. And I'm going to flip to the next slide. This is information coming straight out of the State Chronic Care Initiative registry. All the practices in the region that participate, the 32 practices, were obligated to put their results into the registry. And then from that, we managed the data and the reporting. And this shows just how dramatic an improvement in quality of care we are seeing in the patient-centered medical homes over 5 serial years. Much more improvement than what we're able to see in our network as a whole. And then you might say, well, yeah, okay, that's great. If you're focusing on chronically ill patients, what about prevention? So we looked at one of the larger categories of prevention, cancer screenings. And in fact, you can see by the divergence of the lines here that the medical homes reduced care gaps more than non-medical homes reduced care gaps in this 5-year, essentially a 4-year study here. So the docs are not only managing chronic illnesses better, they're also doing preventive screenings. And probably that comes with the, the underlying tenets of a medical home, trying to coordinate and manage care better. And then you might question me and say, yeah, but did you read the JAMA article on the Southeastern Pennsylvania Chronic Care Initiative? And what I would like to say about that is, while it was an accurate study in that it represents the outcome when you look at all patients in chronic care or in the patient-centered medical homes in our chronic care initiative, all 32 practices. The results are a bit deceiving, because when we started our initiative 8 years ago, the focus was not on managing the total population. The focus for the first 3 years, year one was to become NCQA recognized, and that was the first year the NCQA standards were out. So there really wasn't a lot of care management emphasis in year one. It was doing the things, the infrastructure things that you have to do to become a medical home. Year two, we picked asthma in pediatric practices and diabetes in adult practices, and our focus was on transforming the way we deliver care to those chronic conditions, with the obvious end goal of, after we figure that out, we'll generalize it to all chronically ill patients. The study period looks at the first 3 years, year one, when everybody was trying to become a medical home, year two, when they were trying to learn how to transform care. So everybody's going through lots of PDA cycles here in those first 3 years. And then to complicate things, Mark Friedberg aggregated all the data, so he included all the healthy patients that are going to those practices. And it merely diluted the benefits of the patient-centered medical home. And we actually have published 2 articles since then, and we have 2 more that have been accepted for publication that look beyond the original 32 practices at up to 280 practices, which I'll show you in a moment as soon as the slide switches. The first article came out in volume 20, number 3 of the American Journal of Managed Care, and the second one came out it is a Journal of Public Health Management Practice. I'm looking for the date, all within the past month. And in a nutshell, all 4 of the studies that are accepted for publication, the 2 that have been published, demonstrate dramatic improvement in cost of care and quality for patients with chronic illnesses managed in a patient-centered medical home. The one you can see there shows an 11% lower total cost of care for chronically ill patients, the top 5% of our chronically ill patients. Another study showed a 21% lower total cost of care for diabetics cared for in medical homes. And the impact is largely as a result of reducing admissions. Inpatient care accounts for the biggest single component of the reduction in cost, although ER visits also were reduced. And this is just a copy of the articles. Happy to share those if you like. And the next slide, sorry for the delay here, is, there we go, the reduction in emergency room visits. Now this is across 280 practices, almost 500,000 members, 193,000 chronically ill members, and you can see dramatic improvement in emergency room usage across both the chronic population as a whole and then across some specific diseases. We are absolutely convinced that this has an impact. And I've talked about payment reform. I've talked now about practice reform or delivery reform. And now I want to get into the next step, which is we want to redesign our products to steer patients to patient-centered medical homes. So this is this next slide here is a reference to the city of Philadelphia is one of several large employers that have adopted an approach where if you select a patient-centered medical home as your primary care practice, you have a $0 copay for going to the doctor. If you select a non-medical home as your primary care practice, I think for the city of Philadelphia, it's a $15 copay, and for a couple of our other health and welfare funds, it's actually a $30 copay. Next year, one of the health and welfare funds is actually going to add a differential for specialists. So if you pick a medical home as your primary care site, you not only get a $0 copay for primary care visits, but you also have a lower copay for specialist visits, on the assumption that a medical home is going to coordinate and better manage the referrals to specialists. So we have basically tried to reform the way we pay primary care physicians. We've reformed the way that we support them with data and information and consulting services to help transform the way they deliver care, and we've reformed the products that we're putting out there to encourage patients to select patient-centered medical homes. Net result, we're getting calls from primary care physicians that are not medical homes saying, how do I become a medical home because I'm losing patients to the medical home down the street because you're letting them get away with a $0 copay. And so there's sort of waves of adoption that I anticipate happening. And of course, a very recent change, we created a new company called Tandem Health in Philadelphia, which is intended to link together independent primary care physicians who are of this mindset, wanting to be patient-centered medical homes, to put them together in one company to enable them to take risk, insurance risk, and support them with data information and consultative services to get there. So we're trying to move the whole paradigm from fee-for-service to accountable care in this fashion, and I'll end there, turn it over at this point to our second speaker. Lisa, you can take it away.
Thank you, Richard. So it's a pleasure to be here today. Thank you very much for asking me, and Richard, thanks for a wonderful talk. I'm Lisa Bilski-Watkins, and I'm working independently now, but for many years was associated with the Vermont Blueprint for Health. So I'm going to be speaking about the state-led innovation specifically in Vermont and also some of the national activity. One of the things that we have found looking at the various programs that exist in the United States around a multi-payer primary care transformation is that there are some components that are shared by the program, and they're listed here. I think that it's important to look at them individually because they really are each important on their own and certainly in combination. There's no question that innovative payment reforms have to support primary care, and that the incredible work done by individual organizations needs to be joined together to bring multiple payers together to the table. It's clear for a successful multi-payer process that state government needs to have a convening role, and that standards for identifying and rewarding patient-centered medical home recognition need to be in place. The new staffing models do need to support this new type of care. Those patient-centered medical homes that Richard was referring to really are doing business differently. They're working as a group differently, and we need to look at staffing their practices in innovative ways. In order to achieve both recognition as a patient-centered medical home and to continue on the road to quality improvement, technical assistance needs to be offered and accepted by the practice sites. We need to be able to measure the performance of individual practices and then be able to aggregate into the larger population measures, and that obviously requires a common measurement or a series of common measurements of performance. And then in order to really solidify the lessons learned, that learning has to be collaborative so that people who are doing this work can share their experiences with each other. So this is a busy slide, and I apologize for that, but I want to point out that the multi-payer payment innovations have a couple of different forms, and specifically in the demonstration that Vermont and actually Pennsylvania and a couple of other states have been involved in the multi-payer advanced primary care practice demonstration from the Innovation Center at CMS, has allowed for a number of different payment mechanisms. First of all, just in the blue box, you can see at the top, the participating insurers include a large number of insurers, Medicaid, commercial insurers, some self-insured, and Medicare involved in the demonstrations through CMS. So fee-for-service is alive and well. As everyone knows, the practices are still receiving payment for services rendered on an individual patient basis. But in addition to that, and it's unchanged, the payments are also delivered to the practices and in some cases to another entity to provide additional services that otherwise really would have fallen between the cracks. So it's a per beneficiary, per month payment, if you will, a capacity payment, allowing for specific activities to take place. And as you can see from the blue arrows, these are the per beneficiary, per month payments. And in various programs, they would focus on various ways to deliver those services, whether that was for practice-based care coordination or a local multidisciplinary team, which was now evidence in Vermont, Maine, and a couple of other states. And in some cases, actually in all cases, there would be some targeted care management, really focusing on patients with complex chronic disease and areas that have been demonstrated to really be very intense cost centers. So as we heard very clearly from Richard's good, wonderful presentation, that there have been some very effective payer-specific primary care transformation programs. And I think it's safe to say that the group in Philadelphia was one of the early adopters of primary care transformation. And there are many examples of this nationally, some within specific systems and some branching out to multiple systems. And certainly these collaboratives led to the selection of the markets that have been involved in the Comprehensive Primary Care Initiative, as well as prior to that in the multi-payer advanced primary care practice demonstration. In addition, there has been a great deal of state-led support, and I wish it were in every state in the country. It's not yet, but we certainly are seeing some, once again, early adopters of this type of primary care transformation. Many of those were in the MAPCP demonstration, which actually predates the Affordable Care Act and therefore the establishment of the Innovation Center at CMS. In some cases, there was founding legislation at the state level or regulation, which really served as a very strong catalyst and really paved the way for innovations to roll out. So just as a little bit of background, the Centers for Medicare and Medicaid Services has been supporting multi-payer primary care transformation in two major initiatives around in the last several years. The Medicare MAPCP demonstration is involved with 8 states, and as I said, including Vermont and Pennsylvania. It was authorized before the Affordable Care Act, and it is scheduled to expire at the end of this calendar year, with an evaluation that extends several years beyond that. The Comprehensive Primary Care Initiative is a second demonstration with similar lines and some major differences. It's currently in 8 states, although we're technically in 7 markets, and has a 4-year test period, once again, with an evaluation that extends beyond the expiration, at least planned expiration, of these initiatives. So by definition, any demonstration is going to have an end date, which potentially pulls the support from Medicare from those programs. So there's been some support for these collaboratives of multi-payer programs, and most notably the Milbank Memorial Fund, which is a fund based in New York City, has supported the multi-state collaborative initially for several years, 5 years actually, initially just for the MAPCP states and a couple of others that have been involved, mostly in the New England region. And as you can see, the focus has been on shared learning and quality improvement, really the AAA and looking at clinical outcomes process in terms of how the work is done, and certainly the experience of both the delivery and the receipt of primary care and other services, and then looking at utilization and cost. There's a very keen interest in continuing these interventions on the part of the states and organizations that are doing the work. Specifically, there feels to these organizations feel that there's a huge benefit to the all-payer per beneficiary payment methodology, and what we wish to act on the evaluation results of those programs. And then the Milbank Fund has also supported the Patient-Centered Primary Care Collaborative, most notably recently supporting the Patient-Centered Medical Home Impact on Cost and Quality, which was published in January of this year. This is a list of the states and markets that are actively involved in these multi-payer advanced primary care practice and comprehensive primary care initiative demonstrations. In addition, there are several other states that have really moved far along the spectrum in terms of multi-payer activity. And this actually is an incomplete list in terms of all the states and organizations that are doing this type of work, but this is the current membership of the multi-state collaborative as it stands. In addition, the Commonwealth Fund, through working with the National Academy for State Health Policy, has been a strong supporter of the multi-payer type of activity. They have provided now 4 years of technical assistance grants to states that would compete for the opportunity to do so and work with NASHP. And this has been a very exciting transition as new and individual states have been pursuing multi-payer primary care transformation initiatives. So for those that do not have are not participating in a demonstration with CMS, they have the opportunity to do some multi-payer work. And on the next two slides, you can see that NASHP has been doing this, really collating the information about it, the states that are doing medical home activity. And this is, you can't really see it on this slide, but the link to the website at NASHP allows you to look at this, and these are beautiful interactive maps. So this one is just specifically for patient-centered medical home activity. And the next one is a little narrower, looking at multi-payer medical home initiatives. So I want to talk a little bit about the state of Vermont, and just to give you some sense of the specific flavor that we have been able to focus on here in our state. So I've taken the previous slide that looked at all the different sort of payment methodologies, and the things that are in red are areas that Vermont has really focused on, specifically with some of their Medicare funding through our demonstrations, and actually an underlying and far preceding commitment on the part of the state in terms of our previous governor, our current governor, and the legislature for the last 10 years in terms of what can only be described as activist activity around health care reform. So another busy slide, but I actually like this bubble diagram, and credit goes to Dr. Craig Jones, who is currently the Executive Director of the Vermont Blueprint for Health, for putting this sort of scenario together. I would like to direct your attention to the large circle on the left, the very core of the work in Vermont around healthcare reform, and the Vermont Blueprint for Health in particular is really trying to provide barrier-free access to services that support the health of the population. And at the very center of that is what we call our core community health team. This is a multidisciplinary care coordination team that serves any patient who is a patient at a practice that has been recognized as a patient-centered medical home and is part of the Blueprint for Health. So we have a foundation of medical homes and community health teams that work with them that support coordinated care and linkages with a broad range of services. So it's really expanding what the definition is of health and well-being. Underlying this set of circles is a multi-insurer payment reform framework. Without that type of payment reforms that we have in Vermont, which is actually compelling our commercial payers, Medicaid, and then because Medicare joined us in a demonstration, to participate financially in the Blueprint. That has really allowed for this program to really rocket and take off. We have a health information framework that is always in development, certainly strengthening every year. It remains a challenge, but you absolutely have to have access to accurate and timely information about patients and communication between providers of services. And then the evaluation infrastructure needs to be robust, as it is, looking at the triple aim in evaluating our clinical outcomes, cost and utilization, and the experience of care, and also really the cultural changes that happen as you start to put into place these innovations. Back to the large circle, you'll see at the bottom of it, it says Extended Community Health Team. These are professionals who are working with the core community health team as well as with the primary care practices, and they are delivering targeted services to patients with specific issues. So these are funded separately, not through the blueprint per se, but they are working very closely with our community health teams. They're all considered part of the same community health team, and they work hand in glove together to deliver the services. Specifically, we have very intensive Medicaid care coordination. We have Medicare teams that are based in our housing hubs, which really deliver services to high-risk seniors and patients with disabilities who live in those subsidized housing sites. And then we have some very specific services for patients with opiate addiction, and specifically treating them with medication-assisted treatment supported in the primary care setting. This gives you a sense of the growth and development of the Vermont Blueprint for Health over the last several years. Starting in 2008 was really the very beginning. As you can see, it was only a handful of practices that were involved in our initial pilots, and that was true for the better part of 2 years. With the MAPCP demonstration initiation, which also coincided with legislation in Vermont specific to requiring our payers to participate financially to support the work, the number of practices has steadily grown in a very steep way. And you can see that our number of patients who are actually in practices that are part of the Vermont Blueprint for Health, which means that they are recognized as patient-centered medical homes and that they have access to a wide variety of services through the community health team, numbers at over 500,000. That's very close to the entire population of the state, which is at 635,000. You can also see the number of recognized practices is now at 120. This is actually information at the end of 2013, so it's changed a little bit since then. And CHT-FTE refers to the full-time positions at the community health teams scattered around the state. And you can see that that's a significant number as well, 120 people. I wanted to this is a very confusing appearing slide, but it's actually a wonderful visual because it actually is a visual representation of really the relationships in a specific health service area in the state of Vermont. The state is divided up into 14 health service areas, which largely are around community hospitals, many of which are critical access hospitals and all of which are nonprofit. And in each of these areas, there has been specific community-based work to create the community health team, to bring the practices into a point where they can get patient-centered medical home recognition, all the work that's done on the ground, and the frequent communication between organizations that are not traditionally part of the health system, as it were. So if you look at this picture, it's this outrageous set of nodes, which are sort of where the communication goes back and forth. And this was done through a series of surveys and observations. This is work that's being done by the University of Vermont College of Medicine for us. And the nodes and the size of them there's all this math behind it, and I don't begin to even pretend to understand it, but we really can start to see who is at the center of the communication in these organizations and in these places, specifically health service areas. And how is the culture changing in terms of the way that organizations and individuals communicate around the health and well-being of the population. So the question always comes, and appropriately so, what is the return on investment in terms of what's been put into this set of innovations, and what are we getting back? This is lifted directly from the Vermont Blueprint for Health annual report for 2013. For the first year, this annual report, we were able to demonstrate statistically significant improvements in the total cost of care for patients who are in the Vermont Blueprint for Health. This is just an example of Medicaid expenditures by major category. And you can see that for practices that became patient-centered medical homes, comparing them to a group that is not, you can see improvements everywhere. But also on the right, it looks like there's a blue line that's higher than the red bar, and that's specifically for special Medicaid services. So in this particular instance, this is an interesting example of traditional medical services being utilized less, and services that Medicaid still pays for but are not actually medical services, such as transportation, other things that certainly contribute to the health and well-being of a vulnerable population, actually having more money being shifted into that. So it's an interesting example. A trend of the cost and utilization improvements is absolutely the case in Medicaid, in our commercial payer populations, and also in Medicare by our own evaluation. CMS is doing their own independent evaluation with RTI International, and that has yet to be released, but that is very interesting information that will be available to the public in the future. So I just want to end with some comments about sustainability. I think that we have an opportunity at the state level and nationally to really make a commitment to continuing the successful innovation strategies that have been implemented in a number of states and markets. Unfortunately, when the way a demonstration is designed, it really has a misalignment of the date where the demonstration ends and the date where the evaluation ends. And as a group supported by the Milbeck Memorial Fund, we are asking the CMS consider extending the demonstration to continue at least as far as the end of the evaluation, so we can really learn from what the demonstration has put forth, what are the pitfalls, what are the advantages, how do we modify the way we've done this work in the future. So it's very important to not dismantle the patient-centered medical home support infrastructure that has made a big difference for the lives and well-being, and now we're seeing cost outcomes in our population. So one word about the chronic care management fee, which we feel is a huge and important step supporting practices that are not do not have the opportunity to be involved in some of the demonstrations that CMS and CMMI are involved in. And it's, we're very excited about that as an option. It really recognizes that the complex care that Richard was referring to, and that we've certainly seen in the other states that's ongoing with the patient-centered medical home activity, it's very important to support that work and not expect that somehow it would happen in the 7.5 or 15-minute office visit that is traditionally something one can bill for. It's still a fee-for-service mechanism, which we feel that the per beneficiary per month mechanism needs to be further explored and perhaps extended. And it certainly does not replace the capacity to build the community health teams to create this barrier-free access to services that otherwise would not be attainable for most people. So I think there's a lot of balancing involved here, and we're looking forward to continuing that conversation with our colleagues around the country and with CMMI. And I think that's the end of my presentation. These are just some resources that you certainly hope you take advantage of. There's a huge amount of information about the Innovation Center activity, and it's a wonderful resource. The Vermont Blueprint for Health does have the most recent report on the website, and it's readily available. Those beautiful maps are at the Resource Center from NASHP, and the Milbeck Memorial Fund has its own website, and very interesting information, and a quarterly that is well worth looking at. So Tara, I'm all set.
Thank you, Dr. Dolsky-Watkins, and thank you, Richard, Dr. Snyder, for presenting today and really providing our audience with an overview of what is going on in the states on both the public and the private sectors around medical homes. We have a few questions already. I want to remind our audience that to submit a question, there is a on your webinar dashboard, there is a question box, and you can just type in your questions, and I will ask them to Richard and to Lisa as time permits. One of the first questions we had is related to the payers, and how are payers stepping up to support PCMH? Are they, you know, traditionally they tend to be more to be in competition, and this question is around if they are collaborating, and how so specifically.
So this is Rich Snyder. In our region, all of the major payers participated in the chronic care initiative, but that's a tiny slice of the total population of primary care physicians. So out of over 3,500 primary care physicians in the region, that only accounted for 150. The unfortunate news is that we're the only ones paying extra to patient-centered medical homes for the rest of the 297 practices and 1,492 physicians. And that's a sore spot with the provider community. They're frustrated by it and have tried to get the other payers to step up, but without much luck. And just at a national level, I know as one of the CMOs of a Blue plan, we get together quarterly with my peers, and virtually all of the Blue plans at this point have an approach to reimburse patient-centered medical homes differently than non-medical homes. And in some states, there's fairly mature programming in place, such as Michigan, Care First, Rhode Island, and WellPoint has stepped up big recently as well. So, I think the Blues recognize we're in each state we have a local relationship with providers. We recognize the importance of primary care and we want to support it. That is not necessarily true of people who are or companies that are really focused on shareholder profits.
So I'll just add to that. Depending on the state, there can be a surprising amount of collaboration and willingness to really come to the table together to do this work. But I think that there remains, depending on where you are, it may or may not be successful. Certainly legislation helps and is not fair. I mean, if you have legislation that compels the payers to participate, and that is a very rare situation. But just in terms of the history in Vermont, I mean, to their credit, our major commercial payers were at the table, involved in the development and plans for execution and evaluation of the blueprint from the very beginning. And they remain very important stakeholders, and we have advisory committees on which they serve leading roles. So I think that collaboration is possible. One of the features of the Comprehensive Primary Care Initiative is that it does bring all the payers together in a particular market. So there are different mechanisms that are being tested, and the question is what's going to work.
Thank you. We had another question specific to the coordination of benefits and how are the coordination of benefits addressed using both public and private plans?
I'm not quite sure what that question is aiming at. We have in our market Medicaid, Medicare, and commercial populations, and for all three of them we have arrangements to pay differently for patient-centered medical homes. And when a patient is both, it has a couple of coverages, at least for our Medicaid company in this region, we do coordinate the care between the commercial and the Medicaid. So children with special needs, for example, who have primary coverage perhaps through the family's insurance and secondary coverage through Medicaid, our care managers work together. And fortunately, we make up the vast majority of the Medicaid population here, so it's not there are not a lot of people that we're not coordinating with. But and I'm not sure if I'm answering the intent of the question, but it's what comes to mind.
Yeah, I'm not quite sure of the what was behind the question either, but I'll answer one piece, which is that in Vermont, specifically the access to the community health team, which is care coordination and either directly delivering services around care coordination or doing referral and tracking, is completely agnostic to insurance status. So even patients without insurance have access to those services if they go to the practice that has been recognized as part of the blueprint. So it's a sort of a moot point in terms of the delivery of those services.
So the PCPCC has a special interest group specifically on behavioral health, and certainly our members are very interested in what is going on in terms of behavioral health. And this question is asking, how has the integration of behavioral health services in primary care been implemented, especially in light of the difficulty accessing behavioral health information with EMRs? Can either of you take a stab at that?
Yep. Sure. Obviously, a well-informed question. In our region, and I can only speak to our region, we have imposed in the Chronic Care Initiative, and then for us at least more generally to the other 297 practices, if you want to hire behavioral health providers and bill for those services, that's fine. You can do that. If you want to co-locate an existing behavioral health provider in your office and work side by side, that's fine too. We'll allow that. We promote it. We've actually assisted in getting some practices who are interested, providers, to work in their offices. I personally practiced in a setting like that, and I found it very, very helpful and helped to inform the treatment plan for the patients. In terms of EMRs and super protected information, there's HIPAA, but then at least in Pennsylvania there are additional protections afforded patients for behavioral health and substance abuse, which preclude sharing of information, and that makes it difficult. I will not deny that, but we're trying to get care to be integrated where we can.
So we've got a similar mechanism, and certainly the question about the sequestering of health information specifically around mental health and substance use is important, but also very highly problematic. That being said, there's been incredible advances in the integration of behavioral health in the primary care settings, whether that's actually embedding counselors and social workers in the primary care a couple of days a week, or having a different type of referral mechanism so that patients are referred in a more rational manner in terms of whether they need a brief intervention or more extensive intervention. There are multiple mechanisms that are used, and we've certainly found that that's one of the most embraced and important pieces of the support that the community health team can provide to a practice, because that's the kind of piece that is very difficult to try to fit into the busy hours of a primary care roster of patients.
Thank you, Lisa. I think we have time for one last question, and this one is in regards to some advocacy efforts. And this person is asking if either of you have any advice for physicians or practices or healthcare systems on how to approach and advocate at the state level for such innovative multi-payer models for medical homes. Specifically, this individual is interested in for children with special health care needs or medical complexities. Lisa, do you want to start?
So I'm sorry, the question is what would be the sort of steps to
advocate at
yeah.
the state level for multi-payer models?
So I think that there are multiple opportunities. Certainly the PCPCC is an excellent choice because I think there's a great deal of interest and as well as a really huge breadth of the types of organizations and individuals that are involved. Please, feel free to contact me. I would be glad to connect you with, depending on what state you're in, because I think sometimes it really comes from the state level around that type of work. And there are child health improvement programs all over the country that are really doing this type of work, especially around children with special health needs, some of the CHIP type of programs. So I'd be happy to help you direct you and put you in the right direction.
Thanks. Richard, did you have anything to add to that?
No, I think not terribly. I'm just thinking about it from my perspective. To the extent that you have evidence that care would be better coordinated and outcomes would be better, I think you have to have that kind of information when you're presenting to your state, and presumably it's to the Department of Public Welfare or their equivalent agency in your state. In Pennsylvania, at least, we have found them to be very much engaged and participatory in developing programs for that population.
Great, thank you. Well, I just want to thank both of our speakers today, Dr. Snyder and Dr. Dolsky-Watkins. Just a fantastic overview of what is going on in those states. And I want to thank our audience for participating in today's national briefing. We hope you can join us for our next briefing on May 22nd. And as a reminder, the slides and this recorded presentation will be posted on our website within the next 24 hours. Once made available, you can access them on pcpcc.org/webinars. And I hope you have a wonderful afternoon. Thank you, everyone.